Hello everyone. Now we will be studying about the DIC. What is DIC? DIC means Disseminated Intravascular Coagulation. Now what happens is it is an acquired and a systemic thrombohemorrhagic disorders. It is characterized by your two things. What are the two things it is characterized by? It is characterized by your widespread activation of your coagulation cascade. And next thing is your consumption of platelets. Okay, this thing you need to keep in mind. Now, what happens in the first scenario when there is widespread activation of your coagulation cascade? There is formation of microthrombi in the microcirculation. Then, what happens in the consumption of platelets? This leads to the bleeding tendency and often secondary to any other underlying disease. Okay. What are the pathophysiological mechanism you have? You have two mechanisms. What are the two mechanisms? First one, there is activation of cascade. Okay. Second thing is there is consumption of coagulation factor. There is consumption of coagulation factor. Now what happens in the first one? In the first one, when there is excess of activation of coagulation, this leads to your microvascular fibrin deposit. All the microvascular fibrins are getting deposited, which will cause ischemia to the tissues. And guys, we have read in our journal pathology also, when there is ischemia, when there is loss of blood supply, what will happen? It will lead to the organ damage. When there is consumption of coagulation factors, it leads to your bleeding diathesis. Okay, this means it is a hemorrhagic phase. Now, what are the major etiological triggers you need to know? First are the obstetric cause, then infection, then malignancy, massive tissue injury, and miscellaneous. What are the obstetric cause? First one, amniotic fluid embolism. Second one, retained dead fetus, abruptio placentae, septic abortion, preeclampsia and eclampsia. Preeclampsia and eclampsia is related to your hypertension. Then you have infections like in gram-negative sepsis and gram-positive bacterial, viral or fungal infection. What are the malignancies? In the malignancy, you have your mucin secreting tumors, adenocarcinomas, and acute promyelotic leukemias. These are the three malignancies which you need to keep in mind. Massive tissue injuries are due to any trauma, burns, major surgery and crush injuries. Miscellaneous. In miscellaneous, you need to remember there is snake bite, heat stroke, shock and incompatible blood transfusion. Coming on to the pathogenesis. Now, stay focused. Listen to me very carefully. First step is when there is triggers of coagulation cascade. What happens? It releases two things. Okay, two main principles which you need to keep in mind. First, there is release of your tissue factor, then there is widespread endothelial injury. In the first one, what happens is there is damage to the endothelium, placenta or tumor cells, as a result of which the extrinsic pathway gets activated. Then comes the second one, where there is widespread endothelial injury which causes sepsis, shocks and burns, which leads to the exposure to the endothelial collagens. Okay, step 2 is, what was step 1? When there is trigger to your coagulation cascade. Step 2, when there is thrombin generation. Now what happens is this thrombin gets converted into fibrinogen, which finally gets converted into your fibrin. Okay, step 3 is consumption of platelets and coagulation factors. Now what happens is there is consumptive coagulopathy of factor 5 and factor 8. Okay. In step 4, there is secondary fibrinolysis. This means the plasmin is activated. Now there is fibrin degradation, as a result of which the platelet will inhibit the platelet aggregation and fibrin polymerization. What are the morphological changes? First one is your microthrombi. In microthrombi, they are found in your capillaries, arteries and venules. Look at this morphological changes. There will be ischemic necrosis, especially in your organs, and especially in your kidney, adrenals, brain and lungs. In the hemorrhages, you need to remember there will be petechiae formation, 𝗖𝗵·phis and internal bleeding. What are the clinical features? In the clinical features, in the first one, that is the acute one. In the acute one, there will be the symptoms will be from days to months, right? Like, or from hours to days, right? There will be bleeding dominance like petechiae formation and echymosis. There will be hematuria and hematopathology. There will be organ dysfunction like in shock, CNS distribution and respiratory distress. In the chronic one, in the chronic DIC, it will be slow and low grade activation. There will be thrombosis and it will be more prominent than your bleeding. It will lead to what? It will lead to three conditions: deep venous thrombosis, pulmonary emboli and organ ischemia. This you need to remember. Now this table I have made that represents all the laboratory findings. The first test that was performed was platelet count. In platelet count, in the findings of DIC, I am able to see that it is decreased. Why? Because there is platelet consumption. In the bleeding time is increased. Why? Because due to the platelet depletion. Prothrombin time is increased due to factor consumption. aPTT is increased due to factor consumption. Thrombin time is increased due to low fibrinogens. Fibrinogen levels are decreased due to consumption and degradation. And fibrin degradation products are there due to fibrinolysis. D-dimer test is positive due to the fibrin breakdown, and peripheral smear will show your schistocytes due to microangiopathic hemolytic anemia. What are the complications? There will be severe bleeding which will lead to your hypovolemic shock. In the microthrombi, it will be specific to the organ. In the kidney, I am able to see cortical necrosis and renal failure. In lungs, I will be able to see acute respiratory distress syndrome. In the brain, there will be microinfarcts and hemorrhage. In the adrenal, there will be Waterhouse-Friderichsen syndrome. Then, death will be there if the symptoms are uncontrolled. What are the differential diagnosis, guys? In the differential diagnosis, first one is your liver disease. What is the key differential? How will you differentiate it that it is not a DIC, it is a liver disease? Factor synthesis defect, but normal platelets and D-dimers. Vitamin K deficiency, there will be prolonged BT, normal platelet, and there will be no D-dimer rise. There was a D-dimer rise in your DIC. Primary fibrinolysis, there will be no schistocytes, normal platelets and normal thrombi. And in your TTP, there will be no normal coagulation time. What are the treatment? First thing first, you need to treat the underlying cause by, if there is sepsis, you have to give the person antibiotics. For the obstetric cause, remove the placenta and the fetus. For malignancy, you have to start the patient on chemotherapy. Next thing is your supportive therapy. Blood component replacement. If there is bleeding, you have to give the patient fresh frozen plasma, then platelet transfusion, then cryoprecipitate. To control the coagulation, you have to give the patient low dose heparin. To maintain the organ function, you have to give the patient oxygen, fluids and vasopressors. What is the prognosis? See, prognosis depends on the cause and the severity. If there is acute DIC, there will be high mortality if it is unrecognized. When there is chronic DIC, there will be a better prognosis if the cause is controlled. Coming on to the summary table. Okay, this is your one-stop solution, your summary table. First one is type. Okay, so it is secondary acquired coagulopathy. Pathogenesis, it is widespread coagulation activation is there when there is consumption and bleeding will be there. What are the triggers? Sepsis, obstetric events, trauma and malignancy. What is main problem is that there will be microthrombi and bleeding. In the laboratory test, I am able to see there is decrease in the platelets, increase in the PT and aPTT, decrease in fibrinogens and increase in the D-dimers. For the treatment, I have to treat the cause plus give the supportive therapy. Now, this was all about your DIC. If DIC comes as a short note, this much you need to write. Or even if it comes as a long note, this much is sufficient for you all. Okay, I hope I made myself very clear. If you have any sort of doubt, please don't hesitate. Please feel free to ask me. Please feel free to DM me. Thank you so much.